So our next presenter, Dr. Hal Slavkin, is truly a man who needs no introduction. However, allow me just a few minutes to recognize some of his contributions to dental scholarship, which are many. Dr. Slavkin is a professor and Dean Emeritus at the Herman Ostrow School of Dentistry at the University of Southern California. In June 2014, Dr. Slavkin retired after 45 years as a full-time faculty member. He served as Dean of the Dental School from 2000 to 2008. From 1995 to 2000, Dr. Slavkin served as the Director of the National Institute of Dental and Craniofacial Research, NIDCR. His scholarly interests include healthcare policy, craniofacial genetics, developmental biology, biomaterials, tissue engineering and regeneration, human and microbial genomics, and precision medicine and dentistry. Truly a Renaissance man in dental research. With over 470 publications and 91 book chapters, Dr. Slavkin is a prolific dental scientist and educator. He received the 2015 William J. Geis Award for Vision as a dental educator and the 2016 AADR Jack Hine Public Service Award for promoting oral health activities. At this time, Dr. Slavkin serves as a board member of the Los Angeles Trust for Children's Health and is one of the co-founders of the Santa Fe Group. Dr. Slavkin will present From High-Definition Precision Healthcare to Precision Public Health, Challenges and Opportunities. Please join me in welcoming Dr. Hal Slavkin to the podium.
Thank you very much. No sleeping. Everybody's got to be perky. If you feel like you're dozing off, it's okay, but you won't get a good grade in the class. I learned that today from Raul. So this is my favorite artist, Magritte, maybe some of yours. And I just love this image because it reminds me very much of the human mind and scientific inquiry and so forth, because he's clearly painting what he sees. And this means that all of us have the ability to see what might be called obvious, in this case an egg, or you can look at it as what it might become. And I think when we talk about precision healthcare and public health and the oral health professions, clearly we're at a stage where we might transform into something very different than the typical stereotypes. So high definition precision dental public health care means phenotype plus genotype plus the environment and the behavioral issues that go with that equal precision healthcare. So the add-on is really genotype. We've all gone to physicians, whether they were pediatricians or docs that take care of adults, and we've all been asked about our brothers and sisters and mothers and fathers in attempt to see if there's a pattern. So that's not new. We all know that we have a blood type. We know that there are certain things about our blood type that mean we can transplant or give blood, or we can't. And there are reasons for that, again, coming out of the history of 20th century genetics. So a magical moment took place in 2015 when President Obama was giving the State of the Union address, and he mentioned that he had a new initiative called precision medicine. That, of course, was in the works before January of 2015, and Francis Collins and the team at the NIH were all poised to translate what the president said, assuming Congress would put up the appropriate budget to start funding things as quickly as possible. And I'll mention that. So I'm basically going to take this journey to today, if I can, and sort of highlight how to frame this, sort of like, who are we? Where did we come from? Where are we going? What's this really all about? Well, one of my champions who unfortunately died way too young is a woman named Rosalind Franklin. a very sophisticated European woman who went to Cambridge, set up a laboratory with Maurice Wilkins. She was an X-ray diffraction specialist, and she had a postdoc named Norman Simmons, who was a dental graduate from Harvard. So this dentist isolated and purified DNA from an adenoviral preparation, and that is the source of the DNA that was used to come up with the hypothesis that there's base pairing allowing two strands to form a double helix. It came from her mind, her diffraction studies, and the elegant, clean preparation from Norman Simmons. Ironically, when the Nobel Prize was given in 1964, 3 men only appeared on the stage: Maurice Wilkins, Francis Crick, and James Watson. And ironically, not one of those men mentioned her name, and yet they learned from her because Watson and Crick were in the audience in her seminar, which was held every week, and they saw the data before. But their gift was to make this tinker toy looking model of the base pairing from A to T and C to G, which generated a double helix. So this is the heart of that discovery, and its implications is that it means that there is a fundamental structure in a macromolecule that is capable of copying itself, so it feeds into the concept of cell division and propagating cells and so forth. This molecule, today I'm in front of you with 10 trillion cells weighing 178 pounds. So if you take my DNA, drop me in a Cuisinart, mush me up, extract the DNA, there's enough linear DNA in my 10 trillion cells to go from San Antonio to Boston and back to San Antonio. That's the linear DNA in one individual. This is the paper that Watson and Crick published, 1 page, fairly easy to read. It was published in April of 1953. When it was published, I was a freshman in high school taking chemistry with this very short, energetic woman who I will never forget. And this woman came in one day and was just jumping up and down with excitement that it looks like the secret of life has been discovered. I, unfortunately, was challenged with hormones, looking at the girls, and it just went over my head, and I kind of missed it. So jumping forward a little bit, James Watson became the first director for the Human Genome Project, and because of his arrogance and attitude, a year later, he was replaced by Francis Collins. And under Francis's leadership, this went forward under budget and under time, and it came up with the parts list of being a human being. So it's one thing to lay out all of the parts, meaning 21,000 genes, but the trick is, how do they work, how do you turn them on, and how do you choreograph them into a melody that makes a hand, or a heart, or a tooth, or an eye? That area has been addressed since the end of the Human Genome Project. So all of this were the goals of the project, and all of them were met. The last one comes outside of the Human Genome Project, which is the CRISPR-Cas9, and I'll touch upon that in a bit. So this is the announcement of the 95% draft, which was June 26, 2000. It's in the East Wing of the White House. I'm in the audience. All of us have been hanging around for 2 hours waiting for Bill Clinton to show up. He was always late. Anyway, he comes up, and as you can see, Francis is blushing because he's talking about Francis Collins, and the guy who's sort of sullen is Craig Venter, who represented the private company of Celera, who competed with the NIH in this project. Both outfits published their findings of the 95% draft in the same week, 2 days apart, one in Nature and one in Science. Now, in dentistry, we're comfortable with how we typically are looking at phenotype, to your left, And then the idea is, can we add genotype to give us insight if there's pocket depth, rapid bone resorption, rampant tooth decay, et cetera, do we have tools that can allow us to look at the microorganisms in the mouth, so-called oral microbiome, as well as looking at the host, the individual, and his or her immune system, saliva, buffering capacity, all of those kinds of things. So phenotype has been around forever when we look at each other and we size up one another, and it color of eyes and our urine and our blood pressure and our cholesterol, all of those things are phenotype. Genotype is basically looking at the DNA that's in the nucleus of every somatic cell in our body and the mitochondria, which we uniquely inherit only from our mothers, that are also found in the cytoplasm, generating the biochemical energy to keep life going. And then you throw in addition, dropping down to the human biome, you add all of the microorganisms that live in the mouth, about 7 billion of them, and they're divided into about 700 strains. And to be able to monitor or characterize those all together, the human biome. And of course, practicing dentistry in the near future as an oral health professional might also change a bit, where when we are looking at an individual, we are in our minds reflecting on many things about that human being, in addition to the obvious. And here is an example of a number of genes that have been defined, dealing with lactose intolerance, evening preference. Somebody in this room must have the gene or the mutation for evening preference. You hate to get up early in the morning. You love to stay up late at night. You do your best work after 4 o'clock. I mean, we come in these different types, etc. So then recently, meaning 2013, the FDA approved the fastest, smartest, cheapest DNA sequencer ever developed. Sarah, in her superb presentation this morning, alluded to the drop in cost going from 10 million a human being and now to below $1,000 a human being. And this is an example. That industry in 2013 was generating 4.6 billion. Last year, it doubled to a little bit over doubling to $10 billion. And the two largest DNA sequencing enterprises in the world are China and the United States. In China, it's Beijing, and it's called the Beijing Genomics Institute, and it is now competing with the United States in a very aggressive way, and the United States basically is about 60% of the global market. This slide comparable but a little bit different to what Sarah showed, comparing to Moore's law in the computer world versus sequencing. And right now the Chinese are doing sequencing in American dollars for $400 a person. And Illumina in San Diego is dropped it down to $800 a person. So this starts becoming a number for a nation or a healthcare provider to think about for all people, rather than only those who self-select. So Geisinger in Philadelphia and that area has just finished sequencing 96,000 people in their catchment area. Kaiser Permanente on the West Coast has just finished 100,000, but their data is proprietary. It is for them and for their patients. It is not in the public domain. But the idea of doing population-based screening for risk, diagnosis, smarter therapeutics has not gone unnoticed by the private sector as well as the public sector. So in modern genomics, this slide might be a class in molecular biology. Cells can be popped open, nucleus isolated, chromosomes pulled out. We have 46 chromosomes in a human being, and then we can unwind the DNA. We can look at epigenetic factors as well as gene sequence, and all of this is now something literally being done in high school classes in certain places in the country where precocious kids want to do an AP biology course in their school. So this is what a human being set of chromosomes look like. Notice the size of them. They're named after numbers. So 1 is the biggest and 22 is the smallest. And then my wife, in one of her evening lectures, has taught me that the reason that women are so much brighter than men is because they have this remarkable X chromosome compared to this very miniature chromosome called the Y chromosome. Now, in addition to the 21,000 genes that are encoded and expressed in the course of our lifetime, there's an additional 19,000 pseudogenes, meaning genes that we used to have that are being eliminated, and genes that will soon be birthed as we adapt and go forward in the environments. This is the anatomy of everybody's gene. They start with an enhancer, turn it on, a promoter that determines amplitude of expression. It's too hot, it's too cool in this room, or I need more adrenaline, I need more keratin, I need more globin, whatever the need might be. And then they all end with a stop signal, 3 A's in a row, which means no more gene. So that knowledge base put into computer thinking allows one to quickly do the complete sequence of a human being. Illumina is now doing 12 a day, and that technology is getting smarter. They're in the 3rd generation of sequencing, so it'll go even faster. We've also discovered that there are more than 3 million regulatory regions that regulate this thing called the human genome, and more than 15 million transcription factor sites that are involved in the regulation, orchestration of being a human being and living. Then we know that it all gets down to an A, a C, a T, or a G. So they're called single nucleotides, but they vary. So there's a single nucleotide polymorphism, acronym SNP, and we have millions of these, and it allows a new diagnostic to see, is there a mutation in a particular SNP? Because many Mendelian genetic disorders, there are 10,000 of them, happen to have single nucleotide defects that are responsible for the disease. Here's a collection of faces some of you will recognize, and the difference between 2 human beings on the planet Earth is 0.1%. So the invention of racism, discrimination, bigotry, all of that stuff is social, cultural, but the biology says it's absurd. Then this is something that's counterintuitive. 2 kids are born. They're monozygotic twins, genetically identical. You sequence the DNA when they're born. You sequence again when they're an adolescent. You sequence it again when they're in the 5th or 6th decade of life. The DNA doesn't change, but they grow apart by 30%. One has schizophrenia, one doesn't. One has bipolar disorder, one doesn't, and on and on and on. So the reason for that is called epigenetics, and it means the addition or deletion of a methyl group from either a C letter, cytosine, or a G letter, guanosine. So because of Watson and Crick, and because of this incredible investment by the American people and many other nations in this field, these are the fruits that are now hanging from the tree that are impacting energy, biomimetics to mimic certain biological processes, and agriculture, of course, and then the others all related to wellness and diagnostics and disease. So here's some things we've learned. The difference between all human beings, we're 99.9% identical. We're different than chimps by 0.1%. We have the same number of genes as chimps, mice, and fish at 21,000. We are 96% identical to chimps in terms of our genome, and 90% identical or homologous with mice and rats. We're 85% homologous with zebrafish, and our genome contains 7% homology with E. coli. So there is the conservation and carrying on through evolution of a significant number of genes, most of them related to housekeeping. Then a surprise of just a couple of years ago is the discovery that once upon a time, as Homo sapiens were coming on the scene, that's 150,000 years ago, apparently either they were a little promiscuous or they started dating Neanderthal people. And as a consequence, they had progeny, and the progeny went forth. And in this room today, each of us are carrying about 2% Neanderthal genes inside the human genome. Counterintuitive. Or you may know someone in your life. So here is Mr. Obama, and he laid out in his speech and then later in their strategic planning that went live on the NIH website the goals of this project, and he was asking for $215 million into the appropriators to kick in for the following year. This was the funding for July of 2016. The NIH funded a breast cancer genetics program specifically in African American women. 20,000 were recruited, and that study is still going on. And then the others, as you can see, in the institutions that they went to, developing a platform, being able to take all of these things and basically put them on your iPhone or your Samsung device. All of that has been initiated. Of course, it takes a while to do all of these things, but they are rapidly in progress. In tandem, in part because of the vice president at the Bill Biden and his son and those sorts of issues, he volunteered or was appointed to be the advocate, the major advocate for the federal program in cancer. And these are the 10 areas that the NCI, with additional billions of dollars, are going forth. And then oral cancer included. This would be a lesion. This person turned out didn't smoke, didn't drink, didn't lay out in UV light, but was contracted, in this particular case, with HPV-16 viral infection. The genotype was worked up. Then these are all of the choices of the genes that were candidates, and developing this, it became clear that the white arrow is pointing to the mutation that specifically was developed during the course of the life of that particular individual, and therefore the therapy needs to be designed to go after that area and not a garden variety, everybody's chemotherapy. And so oncology has been the first group professionally to jump on this. And today, almost every teaching hospital, every community cancer hospital are using genomics to help with the diagnosis and help with the planning of therapy, that activity called pharmacogenomics. So here is the 21st century soon, genotype plus phenotype plus environment plus behavior. Behavior might be another way of saying lifestyle, translates into precision healthcare for the 21st century. So here, looking the image on the left, a group of people, everybody has the same diagnosis. Thinking of dentistry, it might be everybody's got periodontal disease. Well, it turns out that that isn't a good descriptor. There are different types of periodontal disease, and so to respond into different categories for treatment might give us a much more precise outcome. That leads us to prescribing drugs and medications, and they in turn would be developed to a prescription that would be focused on our particular mutations and what would be the most effective. Meanwhile, human genome editing popped up at the National Academy of Medicine very recently, and a new initiative on the brain, again, a genetic focus on our mind, the neurons, the glial cells, how all of that works. Here are the two women who have literally changed the world of biology, starting in 2012, when they made the observation that bacteria have the ability not to get infected. There is some mechanism in bugs in which if a virus snuggles up to the side of them and tries to attach, they can actually destroy that virus. That concept of gene editing or gene modification came out of the minds of these two women, one at UC Berkeley, the other at University of Paris. And then now, because of the ethics of this, do you do it on germ cells? Do you take somebody and edit out so-called deleterious genes at that early stage or not? In our country, the answer is at the moment, no. In China, at the moment, the answer is yes. So globally, we do not have a global, international, ethical foundation as yet, so there is diversion. So CRISPR is the name of a technique. CRISPR stands for clustered, regularly interspaced, short, palindromic repeats, something you won't have to remember for the test. And these are the applications for them, and they're being used for a better way to address HIV. They're being addressed for oral esophageal cancer by cutting out the mutated HPV-16, etc. The other thing it can do is it can take a human gene and insert it in the right place in a mouse and have the mouse become a laboratory of a human disease instead of a mouse disease. And this has been done with a very interesting, there's a gene called FOXP2, and if it's mutated, you can't hear. And humans on occasion get this mutation, and you're born deaf and thereafter. So they decided to take that gene, insert it into a mouse of strain. It's now called, you can buy these commercially, Beethoven mice. And that is now an accomplishment. The BRAIN Initiative is being done both by the federal government, not-for-profit foundation, and private investigation. And it is a now several billion-dollar activity. Right now it's focusing on imaging and computer sciences and artificial intelligence from 2016 to 2020. And then after 2020, the applications will start rolling out for the human condition, the biggest one being Alzheimer's. Is there a way to determine mutations for Alzheimer's when you are in adolescence, based on studies from Venezuela and Bogota, or a little bit later, and can you design customized treatments for that? We've also learned that all of these vertebrates have hearing and speech, and FOXP2 is expressed in all of them, and so the ability to study them and use them as animal models is quite impressive. Make a note that studying the brain is no small undertaking. It's got 170.6 billion cells in a 3-pound organ, and it also has tens of thousands of synaptic connections, or 100 trillion synapses. So the challenge for this, when you think of the central nervous system, the mind, Alzheimer's, neurodegenerative diseases, Parkinson's, all of those sorts of things, this is a very valuable investment, but it's going to take a little bit of time. So this man, like I was doing, this, in my language, is a prosthetic brain. There's a woman in here named Siri, and apparently she will fetch and so forth. I mean, it's remarkable. So this means this is adopted. It came out in 2003. Almost everybody on the planet Earth has an iPhone or Samsung. They have been adopted very rapidly, but they haven't really yet, until very recently, been thought about in terms of healthcare. So the idea of the ultimate selfie, instead of a picture of yourself, your genotype. This will become a new ticket amongst adolescents. And here is an idea birthed at UC San Diego and the Salk Institute by an investigator, very bright guy named Eric Topol, who wrote a book called The Creative Destruction of Medicine, published in 2012. And on the right side of the slide, those things all exist. Computing power keeps increasing. Social networking is here. The internet is here. Mobile connectivity is here. On the left side of this image is what would be needed in order to use our cell phone as a healthcare risk or diagnostic tool. There are a few things already out on the market and free apps, or you pay something for them, but the idea is to basically take this knowledge base of your genotype, your behavior, the environmental data, where you live, integrate that material, do it wireless, create biosensors that can monitor your pulse, your heartbeat, and those sorts of things, and then feed it into information systems and then be able to apply it. The thought is that this could make doing healthcare more objective. Then we have learned, and today, this morning, in the excellent presentations, we learned about challenges. Challenges in how do you take a discovery, do clinical trials, find out something very valuable, and implement it in one of the most multicultural societies that have ever existed. And so this is now, the NIH has planted its flag on this. It's implementation science, and the idea is to figure out who are you doing this for and what would be the entree to make it happen. For some people, you go through the rabbi. For some people, you go through a Baptist minister. For some people, it's women on women. And some people, it's the Promotora model, Spanish-speaking from the community to Spanish-speaking people in that community. All of that has basically been not avoided, but just skipped over. I want to remind you that in 1990, we discovered that women were not little men and introduced clinical trials at the NIH for women. In 2002, we discovered that children were not little men. We decided that they needed to be in clinical trials so the drug for the child would make some sense. So this is still kind of new, but not new enough. So here's two examples, both publications from the National Academy of Sciences. The one on the right is a fabulous primer. It's called Applying an Implementation Science Approach to Genomic Medicine. You can just take out medicine and call it oral health, and it all fits together very nicely. Very easy to read, a lot of good ideas put out by the this was the National Academy of Medicine, and then published by the National Academy of Sciences. Here is an area we also talked about this morning, and I just wanted to remind us that if you happen to be 60 years of age or older, no clinical trial. If you're 70, no clinical trial. If you're 80, no clinical trial. So that means that in our country, we've got 10,000 baby boomers retiring every day in the United States, and they want to live longer, for sure, but they want to live better. It's quality of life, and we need to have the object of the research in the research. So clinical trials have to be revisited. If you have, maybe you were born with a disability, the chance, like dyslexia and dysphagia, we don't have clinical trials that are addressing those kind of situations. Autistic children, we're also very meager, mostly private sector money, but it's still way, way underfunded for the need. So children, older adults, pregnant and lactating women, people with physical and mental disabilities need evidence-based approaches to healthcare, and that is where you put on your advocacy hat and champion some of those things. It must be done. Then we've got this very real data. I'm a part of this data, and that is we are on a trajectory for 1 out of every 5 Americans to be 65 and older. That means that that group can vote. They have some discretionary money sometimes, and there needs to be, that community would like to be addressed along with the rest of the society. As you can see here, Japan is the winner. Japan is running 25% of its population. 1 out of every 4 Japanese today is over 65. And that means managing chronic diseases, which is where we spend most of our money on people who are a little bit older. In America, the best numbers I could find for this slide is we've got a little bit more than 133 million people with chronic diseases. That population also, one chronic disease of children is tooth decay out of the 4.5 million births. Cancer, heart, arthritis, osteoporosis, type 2 diabetes, pulmonary disorders, periodontal disease, sclerosis, chronic depression, stroke, and so forth. All of those, almost all of them have an oral component. It's typically xerostomia, dry mouth, but there are others as well. We can, each of us, when we get to that stage in our life, 70% of us die from one of these chronic diseases. 75% of America's healthcare costs, that's 75% of $3 trillion, is spent on the end-of-life chronic diseases disorder scenario. So this is a very compelling issue from a public policy point of view. We know, as was pointed out in some of the presentations, these are sort of variables. There are the bacteria that are in the mouth, 7,700,000,000 strains. They challenge us. Then we wage an inflammatory response, which is under our human genomic control. And then the environment, whether we smoke or drink or live in bad places and so forth, are the environmental modifiers along the way. And then genetic modifiers might be there as well. And then it translates into the severity of the clinical disease. This is the human microbiome thinking female at a glance. And so the nasal cavity, the oral cavity, the GI tract, vaginal, urogenital, all of the covering of our skin. If you take the bacteria on my body right now in San Antonio, somehow physically get rid of them, and you put them on a scale and weigh them, I'm walking around with 4 pounds of bacteria. 4 pounds of bacteria. So this biome thing is not trivial. It is significant, and we need to pay attention to it. Basically, it's a ratio of 3 to 1. We have 3 bacteria for every 1 human somatic cell. Then there are these fields coming on. One of them is focusing on strep mutans. This was Wen-Yuan Shi when he was at UCLA. He's now at Forsyth in Boston, developing this thing called a pheromone-guided smart antimicrobial peptide. And that idea has spread to a number of different approaches to manage oral infections. So here is one of our favorite people, Martha Summerman, and in her strategic plan from the Institute from 2014 to 2019, this particular plan stops next year, to enable precise and personalized craniofacial oral dental health care is one of the other drivers. So it has not been missed by NIDCR. This is a quick glance at their portfolio, what is being funded. Either it's at the population level, behavioral research, epidemiology, the various clinical studies, and the basic science and translational science activities. Genomics touches basically everything in the portfolio. So whether it's autoimmune diseases or periodontal diseases or something to do with saliva, the applications are pretty straightforward. So last year, these are, from my point of view and Science Magazine point of view, these were like the hits of the year in terms of biomedical research, most of them emphasizing the CAR T-cell relationship for a chemoimmunotherapy for a number of cancers that have shown remarkable success, such as lymphoblastic leukemia, beta cell lymphoma, degenerative eye, retinal diseases, and then with China starting next month, clinical trials on oral esophageal cancer and AIDS. Then bioimaging last year went for the work on the cryo-EM technology to 3 scientists, and then the FOXP2 gene and the development of the Beethoven strain for deafness. This is just a diagram showing the evolution of this gene and its impact thereafter. So the idea of genomics and all of the possibilities are in place, and it needs to be revisited in terms of policy, ethics, privacy, as was mentioned. All of those have to be, in our country with our values, clearly understood, but they can't be just understood by a group of us at the NIH or some such place talking about this. The implementation means getting the community engaged in the right language, with the right idioms, with the right socioeconomic thrust, and until that happens, we will have clusters of people who are omitted from the advances. So we now are going to have a quick course in human genomics. This was made by a number of folks putting in ideas for public consumption. If you go to your browser, whatever you use, and you type in the animated genome, you'll get this. It's 5 minutes long. And if you imagine it with maybe rap music for one particular audience, mariachi for another audience, you could do some pretty interesting things with middle school, high school kids that would make a difference. And can you put on the last slide? So I needed to show this to sort of bring me down to earth. So I've been in this genomic world, and this is like 35,000 feet up and so forth. But last year, based on the efforts of Bill and Melinda Gates on their global health outreach programs, this was written up 2 weeks ago in the review section of the New York Times, talking about improvements that were made, all of them low-tech. And the numbers are remarkable. 217,000 people every day who live in poverty have been moved out of poverty globally. 325,000 people a day gain access to electricity. 300,000 people a day gain access to clean drinking water rather than cholera-infected water, and so forth. So it's kind of suggests there are some things that are trending in the right directions. Everything doesn't cost money, genomics type thing, but clearly sustained funding from in this case, a not-for-profit foundation like the Gates, because this, of course, is billions of dollars being spent, but somehow we spend the billions anyway, but we don't get those kinds of results. So I was very impressed, and I thought you would, the data set is found in WHO, the UN, and the New York Times. So at this moment, it is time for me to bid you it's over. It didn't hurt. You stayed awake. Bless you. Any questions?
Hi, I'm Piper Bilo. I'm from the Vanderbilt Genetics Institute, and I really appreciated the talk. Thanks very much. It was a great primer. So when you listed the genes that had had major impact on chronic disease risk that have been discovered to date, I noticed none of them had anything to do with dentistry specifically. And I was wondering what you think is the greatest hurdle today still to discovering the ApoE of caries.
Very nice question. Michael Glick, who's the editor of the ADA, is within our group today and is sensitive to what I'm about to say. One of the words is the word dental. The inflammatory process in the human body that deals with colitis or deals with some skin disorders, et cetera, has much in common with one another. So whether it was done for teeth or not, more important is, does it apply to the infections that stimulate dental decay or stimulate periodontal disease? And I think the answer is yes, not wrapped up, but a number of people are basically, they're making a living off of interleukins as a possibility. But you know, if you pick up a textbook and you go to, you know, there's innate immunity and other kinds of immunity, and you start looking at, because the mouth is connected to the rest of the body, the lymphocytes are not going for an address, they're sort of on as needed, monocytes, histiocytes, macrophages, all of those kinds of things. Migration is normal in a human body. So I think there are, but we card-carrying dentist type, we don't seem to think biologically as much as we think mechanically. We're really astute with mechanical solutions like dental implants or porcelain veneers or things like that. We're getting better and better and better at doing those procedures. The equipment is digital, more sophisticated, but the idea of identifying something biological, prescribing something that's smart for whatever the condition is still seemingly new to us. And I'm hoping that that might change.
Thank you.
Thank you so much for your presentation. Actually, the last slide that you mentioned, that poverty is going down, a little bit surprised me that the economy in all countries around the globe is really bad, and I don't know how that would just agree with the point that poverty is decreasing rather than increasing.
Yeah, well, the fastest growing segment of the American population, despite the stock market, despite our president's statements, the fastest growing segment is poverty. It's growing at about 3% a year. So one of the issues is who takes care of that problem? The feds. But how do they take care of it? It's a partnership with the states. So if I'm in the state of Alabama, as an example, and I don't want to pony up my 25% for Medicaid, then I write off a certain number of people in the state of Alabama or Louisiana or South Carolina. So it's seemingly, rather than healthcare being driven by the needs of the human beings, it's driven by people who are doing their own version of accounting to decide where they want to put the priority. And that's a chronic problem, maybe since, I mean, when they say make America great again, I'm not sure what period of time they're referring to. Maybe it's the 1950s. But I lived in the 1950s, and there were problems at that point and thereafter. So it's health policy is economic policy, and it's also prenatal, preschool, K-12 education priority. If those are done well and you have a literate, healthy population, the country should do very well. But making that jump and making education and health into an entitlement rather than a commodity, we seem to be hung up at that point. Please.
Yeah, Hal, thanks so much for a well-structured and very thoughtful presentation. How do we begin, I'm calling upon you here now as an educator, how do we begin to, per your comment about our technical and procedural approach basically in dental education, where do you see the tipping point where this information comes into the curriculum such that we can move dental education into improving oral health as opposed to more improved technical procedures? How do we do that? When does that occur and how does it occur?
My frame of reference for the most part is from a private university. And I learned that dental schools in private institution can raise tuition every year with no one control. So it could be 4% or 5% or 10% increase laid on the shoulders of the students who lay it on the shoulders of borrowing the money for school. So dentistry is the most expensive educational enterprise at a university level in the world, let alone in the United States. That has to change. Faculty have to be, we talk about calibration, but sometimes it means if you think it's a type 2 alloy, I need to figure out how you think, and we'll both come up with type 2 alloy. But we really have to drink the Kool-Aid and say the reason for becoming a healthcare professional, after all is said and done, is critical thinking and critical judgment. And can we measure that? Can we teach to it or model it is the challenge. Because we're not robots, we're capable of much more, but that is part of it. Because dentists don't write prescriptions to speak of, it means that Big Pharma is not interested in clinical trials with things that go into the oral cavity. So that's a non-go. So it's a very odd, our culture has been the antithesis of Howard Hughes Medical Research Institute, and we're losing dental people applying to the NIH, let alone getting the grants from the NIH. It's a period of atrophy, and I don't see a tipping point. I normally see a pony in most things. I don't see it yet.
You always remind me why I always ask the people who invite me to come and speak together with you to never speak after you. It's a losing proposition.
Thank you.
Anything more about epigenetics? Epigenetics to me is a topic that I haven't spoken enough about. Can you elaborate a little bit more? Is it something we can influence? It's something we can do something with? Because I haven't seen much about it.
It's moved very quickly, and literally today there are kits, epigenetic analysis kits, in which you get cells from an individual or cells that you're growing in a dish, and you're wondering, are they aging in a peculiar way, or are they metabolically switching in a different direction, and so forth. And you literally can assess every C and every G in terms of, is it normally methylated or not, and how is it when you're doing your analysis, and it's used for diagnostics. It's been picked up by the National Institute of Neurological Diseases and Disorders. Grants are out there looking at Alzheimer's, looking at bipolar, looking at depression, etc., to see if these are, in fact, when you live in a climate of stress, does the stress translate, biologically speaking, into epigenetic changes? So it's the air or the water or the housing or the I lost my job, or I was gainfully employed and the company moved to China, as they say. That stuff apparently translates in some of us into epigenetic modifications, and they can be identified and measured. Now the trick is, therapy for epigenetic changes is not yet available. Novartis has got a very active program today trying to move that agenda, but it's not available yet. And epigenetic processes begin as early as fertilization. So turning out to be a boy or a girl is controlled, for the most part, by an epigenetic influence.
So any epigenetic change that occurs before I procreate.
Yeah, so, you know, mom or dad is addicted to heroin or cocaine or meth, and that is not in their DNA, but babies are being, in LA County, we have a huge number of babies that are born addicted to something, and the nursing staff goes, I mean, it's a huge undertaking to manage a large room full of newborn babies in which some of them are born addicted, and that's in this epigenetic world. Yes, please, Stuart.
So, following that, I'll try a short question.
Here, I'll run it over.
Is one measure of epigenetic impact telomere length, or is telomere length measuring something else? Because I know it's used as a marker,
Right.
And where does that fit? It's almost like after something's happened, so it's not really telling us a precursor to intervene.
So Stuart asked the question, we've got these chromosomes, and as we age, the chromosomes get shorter, and it's correlated with age. The way that happens is an enzyme called telomerase. There's a lot of focus on that enzyme and how to replenish it. There's an outfit near Stanford called Geron, a private company that exclusively is working on telomerase. But I wish I could go further into that, but it's, I don't know. I don't know. Jeff?
Yeah, just to follow up to Mike's question. The first thing is in epigenetics in dentistry thus far, and particularly in periodontal disease, we tend to be looking at the outcomes of that, the changes that occur in the epigenetic modification of the genes, and we're not doing very much understanding in what's driving that to happen. Environmental factors, as you say, stress, those kinds of things.
Like smoking or
lead
diet
in the
or
environment,
something.
lots of different things there. The other part about it is that, and this in fact came out of North Carolina, we now know that there are certain oral bacteria that will drive local epigenetic changes and may actually be part of that process as well. So it's an interaction between the microbiome and the host that you were talking about.
Yeah, thank you. Thank you. Good point.
Thank you very much.
My pleasure.